No.
Hello everybody, my name is Brian Kelly and welcome back to Talk of the Town. Hello everybody, my name is Brian Kelly and welcome back to Talk of the Town. Now, hello everybody and welcome back to Talk of the Town. My name is Brian Kelly and we have... Hello everybody, my name is Brian Kelly and welcome back to another edition of Talk of the Town. Play a last minute. Hello everybody, my name is Brian Kelly and welcome back to Talk of the Town. We have a very special show for you this week. Now, it's a tough topic, so you may not want to stay on this channel because we're talking about something that a lot of people get a little squeamish about, but we're going to talk about hospice. And one of the reasons we're going to talk about hospice is because we have a new company in town. We have Seasons Hospice, and we have one of the representatives from Seasons with us, and we have some other great guests. So let me introduce our guests to you now. The first person I have here is Aryan Magee, and let me tell what I have on you, Aryan. Aryan Magee, RN, BSN, MMHA. What's that?
A master's in healthcare management.
I knew that, and she received her Bachelor of Science in Nursing at the University of Rhode Island and her Master in Healthcare Administration from Cambridge College. She started her nursing career at Boston Medical Center in 2001 in the medical surgical float pool. She was promoted to charge RN of a surgical floor in 2006 and then transitioned to manager of the same unit in 2008. After 2 years, she was offered the BMC's off-shift operations, was offered the Associate Chief Nursing Officer position. In this role, she oversaw BMC's off-shift operations, the float pool, staffing office, and bed facilitation. After 15 years with BMC, Aryan was given a new opportunity to utilize her clinical leadership skills in her current role as Senior Director of Clinical Operations for Seasons Hospice and Palliative Care of Massachusetts. And she's right here at the Milton facility. Our next guest is Anne-Marie Barron. Now, when I read this, folks, this is unbelievable. Are you ready? Anne-Marie Barron, PhD, RN, PMHCNS-BC. What does that stand for? BS. What, is this a bunch of BS or what is it? Tell me what that means.
It means Psychiatric Mental Health Clinical Nurse Specialist Board Certified.
Nice.
They didn't ask me about that.
And FNAP. What's FNAP?
Fellow in the National Academies of Practice.
Okay, an associate professor and associate dean for students and curriculum in the School of Nursing and Health Sciences at Simmons College. Dr. Barron received her BS in nursing from Boston College, her MS in psychiatric and mental health nursing from the University of Massachusetts at Amherst, and her PhD from Boston College. Dr. Barron has taught across the undergraduate curriculum in a number of courses: psychiatric nursing, leadership and management, nursing research, and caring at the end of life. As well, she has integrated psychosocial content across the undergraduate and graduate curricula. Dr. Barron's teaching, practice, and research interests are focused on meaning and illness. This is tough reading. It's focused on meaning and illness and the understanding and alleviation of suffering. Her central goals in nursing education are to guide and support students as they develop perspectives and skills that enable them to offer healing presence in the lives of their patients. Do you think you can top that one?
I'm sure I can't. I don't have nearly as many letters behind my name.
I only read half of hers. Okay, and then we have over here, folks, you understand this is probably the most highly educated team of guests that have ever been on Talk of the Town. We have Dr. Mark Ostrem. Dr. Ostrem earned his medical degree from the University of Minnesota in Minneapolis, Minnesota. He completed his internship of medicine at the University of North Dakota, Merit Healthcare in Fargo, North Dakota, and completed his internal medicine residency at Mayo Graduate School of Medicine in Rochester, Minnesota. He is board certified in internal medicine and geriatrics. From 2001 to present, Dr. Ostrem has held the academic appointment of Associate Clinical Professor of Medicine at Tufts University School of Medicine in Boston. He is chief of the section of geriatrics in the Department of Internal Medicine at Kearney Hospital. He is active in the American Medical Directors Association. Is there anything else you want to add to that?
That's quite enough.
Okay, so I couldn't talk about this on my own. I had to bring in some experts. So I am most fortunate to have all of you special people, your special people on the show today. But we are going to talk about a topic that some people might not be fully aware of, and may not be taking advantage of some of the services that are available to them. And so we're going to try to give you a little information on hospice and what it means. Because there are some words. I saw the name of your company. What's the name of the company?
Seasons Hospice and Palliative Care.
So the first question I have for our guest, Aryan, what is palliative care?
Palliative care.
Oh, palliative. How do you say it?
Palliative care.
Yeah, that one. Okay, what does that mean?
Well, basically, it's aggressive symptom management. Is someone talking to me?
No. Sorry about that. Go
That's
ahead.
okay. It's aggressive symptom management for people to live the most with the life that they have. So you can still be receiving aggressive treatment towards an illness or a disease, but we are then also making sure that the symptoms of that are managed so that you can achieve the highest level of living.
Better quality of life.
Better quality of life, exactly.
All right. And I saw on the website at the facility you have in Milton, it also said curative. What does curative mean? Palliative care and curative.
Well, it's different. So palliative care, you can still be seeking curative care while under palliative treatment. Because palliative care is a bunch of, we're managing the symptoms of that. So it's healthcare professionals that are consulting on your case in order to manage the symptoms that might be there. But you could, if it's cancer, you could still be going curative treatment for surgery or chemotherapy. And I think the reason why you see that is because the difference between palliative and curative changes when you go to hospice, right? Because hospice, you're not doing curative anymore.
Oh, okay.
Hospice is when you have 6 months or less to live, and through eligibility criteria that is set up through Medicaid and Medicare guidelines, you meet that criteria in your disease progression. And so it changes kind of the direction of the care from symptom management to comfort.
So the goal of hospice is to help the resident be comfortable in their dying, in their end of life situation.
Right, 6 months or less. But it's all about being able to also assess the patient, document the decline. Because people hear 6 months, sometimes they think maybe that's not right for my family member yet. We have had some patients on service for over a year, over 2 years, especially the Alzheimer's dementia patients, because they tend to have a slow decline. But if they still meet the eligibility criteria, then they still deserve to have their hospice benefit.
I might just offer too that I think we reserve the term palliative care for these end months of life, when in fact I think we're really practicing it throughout people's illnesses for years and decades before someone ends their life.
Right.
Hopefully we're always thinking about assuring people's comfort as we're managing an illness, even when we're striving for cure. And so increasingly the emphasis is on the palliation and less on the cure as people are getting closer to end of life. But palliation is something that I think all practitioners do from childhood till death.
So would you say when someone says that doctor has a great bedside manner, would they be really referring to that type of care, the palliative? Is that more the human side? Is that, you saying?
Hopefully, I think it is a holistic approach. So, there are many aspects of providing palliation, and I guess a reassuring bedside manner from the team, including the nursing staff and the physical therapists and whoever else is involved, including the physician, would be, I think, a part of that, lifting up the patient and assuring comfort, which would be both physical, spiritual, and mental.
And I think it's an important point. You started, Brian, by saying there are resources that people aren't always aware of. And I think it's important to distinguish between palliative care and hospice care as distinct services that are available to folks. And as Mark says, every nurse, every physician, every member of the healthcare team wants to focus on creating the best quality of life for the patient and the family, no matter their circumstance. But when a person is experiencing a serious illness, not necessarily a life-limiting illness, but a serious illness for which the usual strategies of comfort aren't meeting the comfort, the pain needs of the patient, then there are teams of experts that can come in and offer consultation. A palliative care service can actually come and consult with the usual team of care to say, have you thought about maybe this strategy or that strategy? And they have a very big sort of tool chest of strategies to promote comfort, to help with pain, to help with breathlessness, to help with agitation or confusion, to help with depression and anxiety, to deal with some of the symptoms that accompany serious illness. You could have palliative care over the course of many years for serious illness, and the palliative care team works with your primary team. But when it would not be a surprise to the treatment team that the patient might die in 6 months, then the patient becomes eligible for hospice service with an aggressive focus on comfort care. And I think sometimes even health professionals are reluctant to raise the issue of palliative care because they feel like they may be prematurely raising in the patient or their family's mind the idea that they could be coming to the end of their lives. And it's important to distinguish the two services. They can go very beautifully hand in hand, but they don't have to go hand in hand.
Well, in my mind, when I hear hospice, I think of end of life.
Hospice is end of life.
So that is the right thing.
Yes.
Okay, all right.
Yes.
But palliative care doesn't necessarily have to be just associated with the end of life.
Now, I always associated hospice with somebody, say, coming to the home to be with the patient or the person that's ill. But when I was at Seasons, you enlightened me a little bit. I'm getting there.
Yeah.
And you said that the Seasons facility in Milton is an acute hospice facility.
Yes.
Can you explain what you meant by that?
So hospice has different levels of care. You have routine level of care, which is often provided in the patient's home. That means, the hospice benefit will allow them to have durable medical equipment, a hospital bed within the place. Maybe they need a BiPAP at night, and something to help them breathe at night.
Thank you.
And so I think what general inpatient level of care is what the hospice house in Milton provides, is a service to hospice patients. So when they have symptom management that cannot be controlled at a routine level of care in the home, they could be transferred there for aggressive symptom management rather than having the family call 911 or go to the emergency room.
Give me an example.
So a lot of times at the end of life, people experience what's called terminal agitation. If you are on the right medication regime, it can be managed so that you're comfortable. But in an acute episode, you might need to have medication changes every half hour, every 15 minutes, because you want to titrate the doses to make sure that that patient achieves the level of comfort that you want them at, but you also want to then monitor it to make sure that that regimen that you put them on works for 24 to 48 hours until you have standing doses where you can transfer that patient back home and then educate the caregivers on how to continue that.
So what I think I hear is that if somebody in this community has someone at home that they're caring for, but then that person's situations gets agitated or they become a little less
short of breath,
confident that they can handle this patient,
right?
They don't have to necessarily call 911. They could contact Seasons and get maintained, brought to a level, get their medications adjusted, and then go back to the home.
Yes.
What percentage of patients end up dying in your facility as opposed to going back home to their own family?
So many of the patients that we take right from the ICUs or an acute setting from the hospital often come to us and pass very quickly. But those are also patients who we sign up for service when death is imminent. Our patients that we take from the field that we care for many months, usually we can find a regimen for them to go back home. I think one of the problems, or one of the areas of opportunity, I should say, is sometimes in the large academic hospitals, they're not having the conversation soon enough. And so unfortunately, rather than referring someone to hospice when potentially there could be 6 months left, we're hearing about them when there might be a week left or days left. I think the benefit is still extreme. The hospice house itself is beautiful, which I'm sure you'll see later, but at the same time, to have a place that's a little bit more warm, and even though it's a couple days, you develop that rapport with the nurses that are on staff and the physicians that round, and it's sometimes a better memory than, of course, staying in a hospital room where it's beeping and lights and people walking in and out. So even though it might only be for a short period of time, I still feel the impact is great.
Is the compensation for acute level hospice care paid for by the hospice capitation, or is there
It's
an
paid
additional?
for the hospice benefit if the person meets the criteria for general inpatient, and then the hospice benefit will cover the room and board. If it is a routine level of care patient, then it doesn't cover the room and board.
But someone might choose to pay for that if
Correct.
they don't have the capabilities of handling the patient at home.
Yes.
Is it more often people who don't have a good family network who end up utilizing that, or?
No. Some of it is cultural. Some families, have the belief that their loved one cannot die in their home.
I never thought of that.
And so that is a piece of it, but realistically, they come for symptom management. It really is people in severe pain, agitation, and often at end of life, it is general inpatient level of care because you do need to medicate and monitor more frequently. I think some caregivers do a better job at home or have the support, but I wouldn't say that our patient population comes there because of lack of support, because we have tons of family members that are in that inpatient center all the time. We do some free care though. About 10% of our patient population is free care. And so we actually have a waiting list for free care patients too. And so some of those patients are ones that definitely benefit because they don't have a strong support system. And those are the ones that sometimes leave the biggest impression on you at the end. So,
Now, Mark, you have a lot of, you're in geriatrics,
Right.
and you have a lot of patients that are in nursing homes, is that correct?
I do.
So, do you find that many people utilize the hospice benefit that are in nursing homes, or do you think it's not well known?
I think that you may correct me if I'm wrong, but previously people in New England were criticized a bit for not being more aggressive about offering hospice earlier. The average number of days in hospice in New England in Massachusetts was 42 days, whereas in other parts of the country it was 67 on average, I understand. That just reflects the fact that we are pretty conservative or reluctant to introduce this very important service, this very important concept that really can make end of life better. So with that in mind, I would say that yes, in the long-term care setting, where very often people are spending the last years, months, days of their life, there is a time where we should be thinking that the priority ought to be on not curing them, not trying to resolve medical problems, but rather on palliation and providing what can be what is a part of hospice care. So the question is, do nursing home staffs provide that kind of palliative care adequately, or does the patient benefit from the addition of a hospice team? And in general, I think the latter is true. The hospice team does bring in some spiritual supports and some additional nursing assistant support, and so people really do benefit. So we need to be encouraged to think about the long-term care setting as one where the hospice team can be a part of people's end of life.
That's why we invited you today. As a reminder.
Well, and a self-reminder as well as, just a reminder to other people. So yes, if someone has an elder in the long-term care setting, bringing in hospice can make a big difference. And my mom passed away last summer, as you know, and she had hospice in the last 6 weeks of her life, and I think it was it helped support her peacefulness in those weeks.
And how old was your mom when she passed?
My mother was 100.
Wow.
Fabulous. Fabulous.
Right, so we're grateful to have had her those years, and grateful that the end could be a peaceful one.
All right. Now, Marie, you have a lot of experience with terminally ill cancer patients, if I recall.
So 1 day a week I spend at Mass General Hospital as a psychiatric nurse on the inpatient oncology and bone marrow transplant unit, working with the nurses around the psychological, emotional, spiritual dimension of the care that they're offering. And in that capacity, I can see some of the patients with the nurses and work with the team of folks on the unit who are caring for the patients. So yeah, working, especially focusing with nurses in the healthcare team on the really powerful and often very beautiful but difficult work that they're doing is something that's been a privilege and amazingly rewarding.
Man, oh man. Well, why don't we look at some pictures of the Seasons Hospice here in Milton. And so control room, if you could put up some of those pictures of the Seasons facility. Now, here's the front door. So it's a beautiful spot.
Yeah.
It is a beautiful spot.
And
Great use of that
property.
space,
Yeah.
huh?
Yes. And what's it go? And there you are, Aaron and Anne Marie. You were out there Monday. And,
You didn't invite me.
if you look behind, I know, Aaron, you mentioned that some of the families have utilized St. Elizabeth's Church
Yes.
for some of their services and everything that you've kind of linked with the facility. So it's kind of a nice picture we're having both of
Right,
them.
we've
there.
had our remembrance services there every so often.
So why don't you tell people what we're looking at here?
Oh, this is the front entry. This is the lobby that you walk into. It is a gas fireplace for some aesthetic please, and it's very homey. It's very warm, and I think it just makes people feel more at ease. It's not as sterile as a hospital environment.
There we go. Okay.
That's the living room and a place for people to kind of get their own respite. It's hard sometimes to sit by the bedside of a loved one for hours at a time. So we try to give them little areas that they can kind of decompress as well. That's the kitchen that the families use. We supply breakfast and lunch in there for them to pick at and snacks. And there's always fresh coffee no matter what time. And that's us in the playroom because there's a lot of little kids to come visit too. So
See, that's something that I wouldn't have thought of.
that's the nurse's station. They'll kill me for having their pictures on there later. And that's us inside one of the patients' room, which are all similar. They all have their own private patio, and they do have opportunity to have family members sleep over. There's pull-out chairs and couches on the way, and we really encourage people to stay anytime they want. It's another view of the rooms.
And what's that picture?
That's us. No. Yep, that's just the hallway. It's just one long, it's 15 bed capacity. And so at times we've been at 15 with the waiting list, and other times, the cycle kind of goes up and down as we get our word out into the community.
Oh, this is the outside area.
This is the outside area. Too bad it wasn't springtime because we have umbrellas and cushions and nice flowers that are out there, but this is our winter decor at
Now,
the
folks,
moment.
look at that picture. Look by the potted plants in the front of the picture, closest to us, and you can see the bricks on the ground. So here's a copy of the bricks. Tell us about the bricks.
So we wanted to do something for people to leave a little memory of their loved ones. Some of these bricks have been left by patients who have been serviced by Seasons, not necessarily at the inpatient center, or they could be at the inpatient center. Some of those, we actually had some staff members who passed away, and so we bought a brick in their memory, and the money goes to our foundation, which gets utilized. We do legacy programs as well. with our patients, and that could be anything from a picture of family members' hands together and framed and given to somebody as a remembrance, or there are some people who wanted to go to like their last Chicago Cubs game or something like that, and we trying to find ways to make their last wish kind of happen. The other thing is we have charity cases where maybe there's a family member that can't really afford for the funeral services, and so we have application process to go to the foundation and offer for some assistance to the patients that pass as well.
And in the back, up in the right corner, Camp Kangaroo. What's that?
Camp Kangaroo. So that's funded if people donate. It goes through donations, and we try to run bereavement camps for children. It happens at all of our sites when we can raise the money and put it together. We had one a couple years ago that was extremely successful, and it's just a place for young kids to come and share their thoughts. And you know, a lot of it is done through play for some of the younger ones. But the thing that was the most impressive that I saw, I wasn't part of it at that time, but I've heard all the stories, is just the kids being able to interact with other kids that understood what it was like to lose a parent or a loved one that was very close to them at a young age. Is just, there's no words to describe that. So we're looking forward to trying to find another donor to do that. So we're hoping that will come up again soon.
So folks, if you're a donor, you own a big company, you've got some extra money, talk to Aaron.
The other nice thing that Seasons offers with other hospices don't is we have a musical therapist who's on our team always. Besides the nurse and the doctors and the hospice aides, we have chaplains and musical therapists. And the musical therapist isn't a requirement, but it's a requirement for us. And it's really amazing some of the musical therapy kind of just reactions that happen at people at the end of life. You know, there's so many stories that I've seen where people come out of this like shell and somebody will tell them a song that they loved when they were a child, and they'll sing that song and they'll wake up and they'll sing with them, and then they'll go back to sleep. And so there's so much to be said about alternatives that can be brought into it. We are trying to implement Namaste care across all of our patients, but right now it's something that we use especially for nursing home patients and people with dementia, which is just a time that's dedicated to them. We have some essential oils that have nice aromatherapy. We usually use a little light cream. We massage their hands and their faces. We play music on the hospice aides' phones just to set that peaceful setting. And it's just a moment to take that time and really dedicate the energy towards that patient and to give them a little bit something extra. And that's something we're hoping to roll out to all of our patients as just an expectation and not necessarily a therapy. So.
Well, did you know that Mark is a very musical family, Dr. Ostrom, and his wife sings with a group. And what's the name? Luminaria.
Luminaria, and they sing at
your place?
Seasons Hospice.
Oh, really?
Right.
I haven't heard them in the inpatient center.
Well, they're probably there on weekends. Are you in their weekends?
Not
Right.
often, no.
They probably sung a dozen times
Oh,
there.
great.
It's a group who arose out of our church, First Parish in Milton, and they're an active group of women who sing at Seasons and for people at home, and it's a part of the music therapy program.
Oh,
and
I
actually,
didn't
the
even know
music
that.
therapist there was one of my wife's students.
Oh, really?
10 or 15 years ago. So,
excellent.
she
That's
really is
excellent.
very proud of this young lady.
Oh, good. It's amazing. I mean, I wasn't, coming from Boston Medical Center, that wasn't something obviously that was involved in my daily life, and so just to see the impact of it, even though I had heard about it and I'd read about it, I mean, it's just truly amazing. So we're blessed.
Well, you mentioned something the other day when we were there. You said volunteers come in.
Yes.
And one volunteer does what?
She makes cookies.
She bakes cookies. Now, I want you to hold that thought.
Okay.
Because Anne Marie had said that she had watched this TED Talk by this, and you might want to look this up, folks, B.J. Miller TED Talk, and he talks about a Zen hospice place in San Francisco, I
Yes.
believe.
Yes.
And this gentleman had an accident in his life, and he became a doctor, and fascinating TED Talk. But what did he say about cookies? Do you remember?
Well, he was saying that that was one of the most important interventions at the hospice center, that even though the patients often couldn't eat the cookies, there was something about the aroma of the cookies and the folks gathering and families gathering and patients gathering in the kitchen. I was thinking of that when we were touring the hospice the other day too. And he said it may sound counterintuitive, but the kitchen is actually a really important place in their hospice center. And cookies are the intervention of choice.
Cookies is a comfort from childhood.
Yes.
But what else did he say? So what was his point? He said the smell. So what was one of his main things he was talking about for hospice residents? About the senses. Remember what he said?
Yes.
So he's talking about the body. The body might be given out on these people, but it can also bring them the most comforting moments. And he talked about, he was in a hospital being patched up after his horrendous accident, and he heard it was snowing out. And his room had no windows, but one of the nurses brought in a snowball. And all he can remember is holding that snowball and having it melt in his hand. Just that tactile, the sensation in the cold and the dripping. I mean, he says it made him feel human again. It just brought him back. And so he tries to take what he learned from his own experience there and teach it in the hospice environment, where even if a person doesn't have all their senses, that it's critical to have them feel and touch. And so I just remember that was a powerful part of that TED Talk. So folks, you might want to check that out. It's fascinating.
It is a beautiful presentation. Yeah, he's very moving.
He was good. Now Mark, Doctor, I apologize. I sing with Mark, you know, the Quincy Choral Society. He's just Mark to me, but to you, he's Dr. Ostrem.
Not just Mark to me, too.
I have to tell you something. He was the doctor to my uncle, and a lot of my extended family have had him and still have him as their doctor, and they've always just raved about him. And Mark, why don't you tell your story, how you got involved in geriatric medicine, because I believe there's a shortage of doctors in that specialty now. It's not one of the highest paid parts of the medical profession, is from what I've read. So maybe that's the reason why, but is there a shortage of geriatric doctors, and how did you get on that track?
To me, it was just what the practice of medicine was all about, taking care of adults. And a lot of adults are older, and they have the greatest stories, the greatest life experience. And I like my grandmas, never knew my grandpas, but so I just found it always it resonated with me to be caring for these people. And it was a new specialty, and that I was drawn to have further training and experience in. So it just made sense to me, and it continues to be very gratifying, I would say. But I take care of adults in general and elders in particular, so there's the broad range of care.
Now, you mentioned they're the ones with the great stories and everything like that. One of the things I read is that today with Google, it's changed a lot of the dynamics. Years ago, we'd go to the elderly for wisdom, ask them questions, how to do things, experience. But now people don't do that as much. They just Google it, you know? I remember talking to my nephew, and I asked him a question about a restaurant or something. We had a conversation. He said, just Google it. And I was like, oh my goodness. So their role in society has been almost taken away somewhat by the internet. And so,
I'm a great believer in the wisdom we accumulate with age and experience. There's a fair amount of it right here, right? and you know, I don't think that Google will ever be able to compete. I don't think any machine is ever going to be able to compete. Watson can win at Jeopardy, you know, this new computing device, but in terms of judgment, caring, you know, putting together the entire holistic story, I think it remains up to us humans to do that. And I think the pendulum will swing back amongst young people to look to the folks who are our age, older, to you know, to share with them the stories of experience and the stories that have our mistakes, so that they don't have to make them over again. one thing I was struck by really early in my career, and you may have found this too, but when I was first practicing medicine and working with older people, I was so amazed at how peaceful people were about being close to the end of life. And I was very struck by that, that there was no fear, there was no anxiety, someone's 85 years old, their number of years left is small, but I just was struck that they had an adaptation to the finiteness of life, and it's a great lesson in working with older people. I think that, and I'm sure you find that in your work with younger people or people of any age who must come to terms with the limited amount of days, weeks that we all have, and it's a struggle to find the peace and the preparedness, but the human spirit is strong.
The human spirit is strong.
And we do it. I wondered about how much spirituality is practiced in the hospice house, and how many pastoral visits there are, and to what extent that's an important part of people's end-of-life experience.
So everybody's plan of care is extremely individualized. So, between our social worker and the case managers in the field or our nurses on site, there is a social worker on site all the time that works there full time. And so really we find out from the patient, if possible, or from the family what they want. We do have chaplains on service, and they are there every day and can be there, and they're on call 24/7. But it's really to make sure that we provide them with the level of care that they want, so that the end of life, because some people might say, I don't want any musical therapist, and then a musical therapist is visiting the neighbor and they hear them sing, and then they're like, oh, what's that? So it's really about education right up until the end. And then it's our priority to make sure that we can deliver anything that's within our scope to deliver. Because one of the things is you don't get a second chance at dying. And you brought up a really good point about kind of when people accept that death is imminent and how sometimes it seems very peaceful for them. And I think another piece of hospice that needs to be recognized, that it's not just for the patient, it's really for the entire family. And so, we also provide bereavement services for up to 13 months after. We follow up with the family and make sure that there's anything they need. So that's another piece that I think people don't think of, because they get that idea of hospice. Oh, it's gonna, people are dying and they're gonna get morphine, and it's gonna be, they have that image. And so it really is much more about taking care of the whole family. So, I mean, from start to finish, it's spiritual, even if it's not religious kind of thing.
I would also, Mark, like to pick up on the point you talked about, the gift of working with elderly folks who are really at a phase of life where there's a sense of serenity and peacefulness about that. And I think one of the gifts of doing this work is recognizing the power of an experience, a serious illness or approaching end of life, as an opportunity for growth, whether it's spiritual, emotional, social. It can be actually a really rich time in people's lives. And the more we can have services and physicians like you, and orientations in our medical centers where we do put the patient at the center and focus on the family, and allow the space for people to really be talking with one another, have the ability to ask the questions that are on their mind, ask them what's most important to them. When we can create these special environments for patients and their families, it's amazingly beautiful work often. And I would posit that we get more from the experience of witnessing that kind of work with that patients and families do than in some ways we offer, that it really is a gift to see the ways in which the human spirit prevails.
Absolutely.
And the sense of what's most meaningful and most important comes right to the fore. And even when there are difficult conflicts, that's often a period in life when there's a lot of motivation to get things right.
Right.
And to really look at love with a capital L
Mm-hmm.
in ways that are very, very moving.
And often it's not even verbal communication. There are these intangible spiritual things that are happening as people are together and sharing their feelings, their grieving. And the bereavement certainly starts before the death, doesn't it? And so to work with people in that time is really, I think, so important.
So important. And as a society, we don't offer a lot of opportunity for that to happen.
Right.
And so having a resource in Milton, such as the Seasons Hospice, is a really rich possibility for all of us.
Absolutely.
And I think doing the tour with you the other day, Aaron, I was really struck by sort of the evolving world of end-of-life care. It's as though you have an intensive care unit for comfort. And dying is really hard. Symptoms can be really distressing, and families can get easily overwhelmed by the needs of their loved ones. So to feel like there's a place where they can turn and actually get the practical, physical help so that comfort is achieved, it's a real gift for this community.
And to have it close to home is important too. I had a patient from Milton who passed away a couple of years ago, and it was before your facility was open, and he had to go to a place in Cambridge. It was really a big, it was difficult for his family to have to get over there through the traffic, at a time when, there were more important things than dealing with the stress of traffic. So it was just really great that we have a facility like this in our community.
It's definitely a blessing, and I think from a Seasons perspective, there isn't another one like it. There's not one that does the general inpatient level of care, and so we're hoping that as it grows, then we can think about, could we build one on the north side of the city, because that's something that comes up because we service people all over the state, and so it's challenging for them if they have to drive to get to the inpatient center, even though it might be the best for them. And so that's something that we think about very seriously. But yeah.
Do you feel that with all the talk of changes to healthcare and that pendulum that keeps swinging, it's like they're trying to get the right mix of what is the right healthcare program. How do you feel this type of service will be impacted? Do you think we're going to be moving more towards providing more hospice type programs, or do you think that's going to, it's going to be like the art class that gets kicked out of the school,
I don't think so. I think, if you look at the cost of healthcare at the end of life, when people are in acute care settings, I think that it is much better for the families and, of course, for healthcare costs to be within the home and managed within the home. So I don't personally see it going away. I think if anything,
it might become more prevalent.
I totally agree with you. There are plenty of statistics published about what percentage of healthcare dollars are spent in the last weeks of life, and one would have to say that much of that expenditure is for futile care. That is, the patient is not getting better, not going to be cured, not going to recover, and will pass away. And yet we put people through unpleasantness. We do interventions that don't improve their quality of life or their quantity of life. And we're not very good yet at being able to have the conversations that will lead to a more rational use of our healthcare services. And when I say rational, I don't mean rationing, because that's what everyone's afraid of. And I think we can provide sensible care by expanding hospice, expanding palliative care, and allowing people to make choices early on about what they might want at the time that life is short.
And giving folks the opportunity to have all of the information that we have at our disposal as we think about their circumstance. In 2010, the New England Journal published a study that was done at MGH, which was really fascinating. They took patients who were had a new diagnosis, but a stage 3 lung cancer diagnosis, coming to the thoracic cancer services at Mass General, and they randomized a group of patients to receive the usual care, which is actually quite excellent, and they randomized another group into usual care plus palliative care, just routine palliative care. The palliative care clinicians were introduced at the second appointment, and then they had availability of speaking with the palliative care specialist when they came in for their routine medical checks. What they found at the end of the study was that the folks who had palliative care lived an average of 3 months longer. They had less anxiety, they had less depression, and they had less request for aggressive, futile care at the end of life. And the idea that they'd have the opportunity to anticipate what might be happening, that they would know what the kind of interventions would be that would promote their comfort, and they'd have the opportunity to talk as a family and as individual patients with a specialist who's comfortable having those conversations, allowed for much higher quality of life. And a side benefit is that it's less expensive care, but perhaps more importantly, it's less futile care that doesn't often add to the quality in those last couple of months.
Well, we're running out of time, and that was a great wind-up to it. This has been a great opportunity to learn more about these opportunities. And I saw on your website that most healthcare plans cover hospice. But if someone has a question, they could call over to Season.
Absolutely.
And so, folks, we've been fortunate today, haven't we? This was a pretty good talk of the town, wasn't it? Man, oh man. So we've been here with Dr. Mark Ostrom. We've been here with Anne-Marie Barron. She's got like a million things, but RN, teacher, professor, scientist, guru. And of course, we've had Aryan Magee with us from Seasons Hospice in Milton. So folks, now don't just drive by the place. As a matter of fact, some people, if they want to volunteer, they could contact also, right?
Yes.
So if you want to volunteer, you want to learn a little bit more about it. And so, don't be shy. And you can always support them on some of their foundation work too. So folks, thank you again for watching the show. It's been fun. I hope you learned something. And thank you all very much for being guests of Talk of the Town. And we'll see you folks again soon. Bye-bye.